We can go ahead and get started here. Thank you everyone for joining us, either here or on Zoom or on Facebook, or watching this recording later, for our Doctors In presentation today on hearing and vision. We are joined today by Dr. Michael Daniel Levich, who is, did I get that pronunciation right? I was practicing. Cool.
You did. First person
Awesome.
ever get it.
Who is going to be leading us through today's presentation. We just a couple housekeeping things before, and after 2 years of doing these mostly through Zoom, probably just a reminder at this point. But you can ask questions at any time using either the chat or the Q&A. The chat, your name does show up publicly. If you're asking anything more personal that you'd rather keep anonymous, there's an option in the Q&A to ask your question anonymously. And there are actually going to be a couple of places in the presentation that Michael is going to pause, and we'll take all the questions at that point. Still feel free to write them in at any time, but don't fret if I don't ask them right away. We'll have a pause for questions on vision, and then some time for questions on hearing. Anyone on Facebook, just jot your comments in as a comment, and I will relay those to Michael. And then for anyone new, Doctors In is a partnership between us as the Elder Initiative at the William Wade Community Center and the Jefferson Department of Family and Community Medicine and the Jefferson Center for Urban Health. And we do these monthly health talks with Jefferson doctors coming in to present on relevant health topics. And we're always very appreciative of them for lending their time and expertise to share with us. So with that being said, I will turn it over to Michael to get us started on today's presentation.
All right, let's get started. Thanks so much for introducing me. And I'm one of the geriatric medicine fellows at Jefferson. Today, we're going to be talking about some common hearing issues, vision issues, as well as how to manage those and how to prevent some of them. So hopefully this will be informative for y'all. Now, we're going to start by going over, even though I've titled it Hearing and Vision, we're going to do it in the opposite order. We're going to start with vision issues, go through that, promoting eye health, talk a little bit about hearing loss, as well as how to cope with that, and some assistive devices and options, some of which are pretty new. So, like many things, vision does change with age. And I wanted to start by going through some of the more common presentations of how it changes, as well as how that may affect you on a day-to-day. So one of the most common, something that happens to just about everyone, is called presbyopia, which basically means that folks tend to get more farsighted as they age, meaning they have trouble seeing objects up close. And you can see an example of that here, where the person on the left may have normal vision, is able to see the dashboard as well as see the nice ocean in the far distance. Someone who is more farsighted may have greater trouble looking up close, so kind of here. Reason for that is because the lens of the eye, which operates kind of like a camera lens, usually is moving pretty consistently throughout the day, meaning as we look close, it moves in one direction, as we look far away, it moves in another. As people get older, as early as their 40s to 50s, the lens stiffens up. And it usually stiffens up in a way that makes our distance vision better and our near vision worse. There really isn't much that we can do about this, which I'll go into in a moment. The reality is we cannot stop this process from happening. Folks often need corrective lenses, either with eyeglasses or with contact lenses. For people who have other vision issues, we have the option of doing something called bifocals or progressive ad lenses, which some of you out there may have already. And those really make it easy for folks who need help seeing things at multiple different distances. Bifocals tend to have a stripe or a portion of the glasses that are for reading, whereas progressive lenses, usually the lower part are the reading part, and then as people move up, it becomes more for distance. They do take some getting used to. So folks who get their progressive lenses at first sometimes come back and say, wow, I really don't like this. It makes me a little dizzy. For some people, that persists and they just never end up really liking them. For others, they do tend to adjust. One thing that I've been asked, even in my own practice, I see adults age 55 and over in the clinic, is What about LASIK? LASIK, for those who don't know, is a procedure that reshapes the front layer of the eye, the cornea. And the general advice from eye doctors or ophthalmologists who are doing this procedure is that after 40, the benefit, we think, tends to go down because of these changes in the eye, because of these presbyopic changes. In folks 40 to 60 years of age, the results have generally been thought to be similar at first, but there is often a need for repeat treatments and possibly an increased risk of complications. So something that we're not doing as often in our folks who are over the age of 55. One of the other changes in vision that folks often see as they age is cataracts. Now, like I said, the lens of the eye is like a camera. As people age, that camera lens becomes gradually clouded in many situations. These are changes that are painless. It's often slow. It's not like folks wake up one day and notice, my goodness, my vision is so cloudy. But people with cataracts do tend to notice a clouding of vision. They may have more trouble seeing at night, or when they look at lights, especially at night, they may notice some glowing halos around the light. So here you'll see an example of normal vision on the left, nice crisp clear flowers. On the right, you see this this is a very dramatic cataract, I would say, but it would be cloudy, harder to discern the features. Fortunately, there is a lot that can be done about cataracts, namely surgical procedures. The way that eye surgeons actually deal with cataracts is by doing a quick incision, usually at the outside edge of the eye, actually removing the existing lens, usually by introducing a device that actually basically shakes it into tiny pieces, removing that, and then placing a synthetic lens, which has this kind of hurricane shape that you look here. Now, the preoperative testing for these lenses usually helps us figure out what kind of corrective power we're going to give this lens, meaning, are we going to make this something for seeing near, something for seeing far? Are we going to do one eye for one eye for the other? And that's something to talk about with the eye doctors. These procedures are really quick. They're 20 to 30 minutes. They are generally pretty safe, even for folks with a lot of medical conditions, to the point where you don't need to come see me in many cases as a primary care doctor to get clearance for this procedure. I said a lot of eye docs still want that. But even if you have a lot of medical conditions, cataract surgery is still quick, still generally safe, and still really, really effective. One of the other things that folks might see as they age are these things called floaters. The globe of the eye is filled with a sac, and inside that sac is a jelly-like substance called the vitreous fluid. As people get older, sometimes starting even in their 20s to 30s, if people are really nearsighted, little bits of this substance will kind of gel up, forming these little specks that float across the vision. Some people will notice them looking like this. This is somebody who I would say has a lot of floaters. Most people do not have this many. The answer, sadly, to what can we do about this is not that much. People usually learn to live with them, don't notice them as much with time. That said, there's one really specific point that I want to say, is that if you notice that suddenly you have a ton of floaters and or sudden flashes of bright light that look kind of like this here, you really need to be seeking care immediately. This can be a sign of a vision-threatening issue. In certain cases, that vitreous sac, which is kind of a sac inside the eyeball, will actually peel away from the back of the eye, which can really threaten folks' vision. So if you notice that the floaters are suddenly popping up or that they're accompanied by flashes of light, really get yourself to an eye doctor as soon as possible. As many of you know, especially those who actually have diabetes, diabetes has some really special considerations when it comes to eye health. Folks with diabetes are more likely to have damage to the blood vessels in the retina. This is something called diabetic retinopathy, the retina being the back of the eye. And what really happens is that these blood vessels can start to get leaky. They start to let fluid out. which can really compromise vision. How do you prevent that? The first step is really, easily said, more difficult to do, but maintaining really good control over your diabetes. In addition to that, really looking for regular eye exams, generally every year, at least for some folks every 6 months if you actually have signs of eye damage, with retinal examinations with an eye doctor. That can be, we'll talk a little bit about the difference between an optometrist and an ophthalmologist in a bit, but as long as you're seeing an eye doctor, they are dilating or expanding your pupil and looking at the retina. That's really what we're hoping for with diabetes. Now, if you do have some eye damage due to diabetes, there are a number of options for attempting to improve some of that vision, most of which are laser treatments. Again, not something that's super painful, not something that is very involved, but ideally we're preventing these diabetic complications as opposed to treating them after. You'll get better results with prevention than with treatment. Another one that I wanted to briefly touch upon that does happen with age, it's more common with aging, is called macular degeneration. The macula is the part of the back of the eye, the retina, that is responsible for central vision. And as folks get older, we often find that it thins. If it thins enough, you can get these small deposits that look like these little flecks of cotton here, and that's known as macular degeneration. Folks who are over the age of 50, who eat a diet high in saturated fats, people who smoke, and people who have high blood pressure are more likely to develop macular degeneration. Now, why do we care about this? I say here it rarely does cause blindness, but it can really affect folks' central vision. I'll show you a little bit about what that looks like. Unfortunately, once it starts, macular degeneration is not fully curable, but again, it can be treated. There are a number of medications which often involve an injection into the eye to treat macular degeneration. This is a pretty standard test for macular degeneration. It's called an Amsler grid. What the ophthalmologist or optometrist will do is they will give you the grid on the left, the A grid, and they will ask you to look at the lines and tell them if they are all straight up and down, straight left to right. Ideally, this grid is a grid. It should all look like cubes. In somebody who has macular degeneration, pretty severe macular degeneration, it will look like it does in B. This distortion of the lines, the curvature of the grid, it often almost forms a spiral and sinks down. And that's due to some damage to the back of the eye, the part that processes central vision. Now here on the left, you see a standard kind of what somebody with excellent vision would see when they are looking at this girl. On the right, you're going to see what somebody with really advanced macular degeneration is going to be seeing. Loss of color, a loss of detail, and a loss of a lot of the vision right here over this ear. Again, it's not complete blindness, as you can see the outside of the image. So what we call the peripheral vision is still very much intact. But as you might imagine, central vision is really important. So we want to be aware that this is developing. We're going to talk a little bit about some strategies for preventing macular degeneration later on. So, with these talks, I often say, we can give you a lot of scary information, but what I like to focus on as well is, what do we do with all of this? So for this next part, I'm going to talk about how we can promote good eye health. And to do that, I want to talk about the two types of eye doctors, because I get this question all the time as a primary. Who should I see? What's the difference? So the first type of eye doctor is called an ophthalmologist. And they are trained either via an MD or a DO degree, meaning they are physicians. They have gone through 4 years of undergraduate, 4 years of medical school, and then a 4-year ophthalmology residency. If you need any type of eye surgery, these are the folks you want to be seeing because they are the surgeons. They are also the ones who do management of complex diseases of specific parts of the eye, meaning the cornea, front of the eye, the retina, or the back of the eye. If you are seeing an optometrist, you are seeing another highly trained professional, another eye doctor, who has a different type of degree called an OD. Optometrists have gone through 4 years of undergraduate training. and then 4 years of optometry school focused exclusively on the eye. Sometimes optometrists will do some further specialization and do a year or two of residency, but it's not required. And a lot of folks think of optometrists as the primary eye care doctors. They do things like vision checks in addition to eye disease management. So really, for most folks, an optometrist can manage most, if not all, of their eye care needs. If you're needing surgery, you really do need to be seeing an ophthalmologist. Another common question, how often do I see my eye doctor? And it really does change. The answer is very personalized based on how good your vision is, as well as what other conditions you might have or be at risk for. For my patients aged 40 to 64, the American Optometric Association recommends at least every 2 years, unless you have risk factors or demonstrated eye disease, in which case they say every 1. Once you pass the age of 65 or greater, pretty much most societies are saying at least every year, unless you have specific medical concerns. So once you're there, what are the eye doctors looking for? Eye exams can be a little bit of a long process because they have a lot of components. The first thing, which is often done by a technician, is somebody will check your vision and see where we're at. They will then often go through what's called a refraction, using that device that they put the lenses in front of your eyes, 1 or 2, what's better, left or right, checking the best prescription for your lenses or glasses. They will do an eye pressure check, which is often the part where they numb up the eye and either place a small device against the eye or blow. In some facilities, they'll use air to actually check the pressure inside the eye. And when that pressure is high, this is called glaucoma, and that can cause vision loss, a different type than we've talked about, more affecting the outside periphery of the eye. The last part of the exam is usually the retinal exam. To do this part of the exam, the doctor will usually use a drop to dilate or expand the pupils, and then they will take a good look at the back of the eye, looking for damage due to diabetes. They will take a look at the optic nerve that connects the eye to the brain, and they will look specifically at the macula to see if they see any signs of macular degeneration. So another really good question that folks come to me often with is, what can I do to keep my eyes healthy? And a lot of this, again, is prevention. Sun protection is really, really important, especially for folks with lighter eyes. My eyes are blue-green. Folks with lighter eyes do tend to develop some more problems in the sun. Our eyes just are not as good as blocking out the rays. When you do wear sunglasses, you want to make sure that they have UV protection for UVA and UVB light. Because this type of ultraviolet light is what damages the eyes, specifically the back of the eye. Similarly, controlling blood pressure. High blood pressure can cause issues with the back of the eye, the retina, a condition called hypertensive retinopathy. Hypertensive being high blood pressure, retinopathy being disease of the back of the eye. So if you have high blood pressure and it is out of control, you should be going to see the eye doctor regularly to make sure that you don't have issues. And if you have diabetes, like I said before, making sure that it is as well managed as possible, that you have regular contact with an eye doctor. As with most things in medicine, if you smoke, work on quitting. Again, easier said than done, but smoking is linked to macular degeneration, development of cataracts, and damage to the optic nerve. So the best thing that you can do for your health in general, I tell my patients, is to quit, and that's true for your eyes as well. The final one that I occasionally have to remind my own partner about, is wearing contact lenses as directed. Don't be reusing your single-use contacts. Don't try to extend your 2-week contacts beyond the 2 weeks. And definitely do not sleep in your contacts. I think a lot of folks in medicine have really seen some pretty significant complications in people who try to overextend their contacts. So if you wear them, use them as directed. And if they're not working out for you, definitely talk to your eye doctor about switching into something that might. Another question folks sometimes have is, what about eye vitamins? There have been a couple of studies on age-related eye disease. And from these studies, there have been 2 formulations of vitamins that have been developed specifically for people with macular degeneration. Now, does that mean that you or I, who may not have macular degeneration, will that benefit us? And the answer is we have not found significant benefit in folks who do not already have moderate to moderate macular degeneration. These vitamins are really meant to prevent the progression of intermediate to more advanced degeneration. One specific thing to think about these formulations, even if you do have macular degeneration, there are two. One is called AREDS, one is called AREDS 2. The original AREDS formulation is still just fine. It has a few different ingredients. One of those ingredients, that being beta carotene, should not be used in people who are smoking cigarettes. So if you do have macular degeneration and if you smoke, you should be taking AREDS 2 and not the original, because there is an increased risk of lung cancer among folks who are smoking and taking the original AREDS formula. Now, other tools that we can use with vision change, not for a specific disease. I feel almost embarrassed saying this, magnifying glasses, it seems really obvious, but some folks don't need glasses all the time, but if you need them for small print, it is useful to have. There are also multiple magnifier apps for your phone, for your computer. Apple and Android devices, under the accessibility features in both, actually have built-in ways to make text appear larger on screen. So really, aside from, we're all about adaptation here. We treat the things we can, we do the procedures we can, we wear glasses and contacts. But when that still isn't doing it, we sometimes need to use other tools. So I will pause for a moment here and give folks a chance, if you have questions, to go ahead and put those out there about vision before we change gears and switch to hearing. So I'm going to mute for a second. And if anyone has questions, happy to hear them.
And again, folks can feel free to put those either in the chat or the Q&A at the bottom of your toolbar. Michael, you may have preempted a lot of the questions by sort of answering all the ones you commonly get asked. I'll share one that I have heard just more, during COVID times, people talking about computer screens kind of being a strain on the eyes. And so I wonder if you have seen that more commonly in the past 2 years, and if there are any of the best practices there.
I think the tough part for me to comment on is that computer screens have been a part of our lives, my life at least, since I've been in training. Over the past 2 years, I haven't necessarily seen more than I did in the past, but I would say that folks who spend a lot of time on the computer screens do emit a certain type of blue light that can affect people's sleep cycle. There can be significant eye strain, especially in folks who may be a little bit more farsighted. So making sure that when you are using computers, to wear your appropriate glasses if you need them, to be sure to take breaks. Don't just be staring at a screen for 4 to 6 hours at a time. Sometimes folks can develop dry eye, making sure that you're using lubricating drops if you're finding that that's a problem for you. And one other warning that I like to give people that I didn't mention in the slides, mostly because I forgot, is when you are using eye drops, say if you're buying over-the-counter kind of saline eye drops, make sure that they are not the ones with the eye redness relief. Eye redness relief drops are rarely useful. They essentially just hide the problem, and they can actually cause some significant side effects. So I would be cautious with those eye drops.
Awesome, thanks, Michael. There was a question going back to the floaters. Just sort of confirming there's not really much that someone can do about floaters.
There are a few things if they are so bad that they are really impeding vision. One of them is basically to remove that vitreous fluid from the eye and actually replace it with a synthetic gel. I have not seen that done often. It is a possibility, but I don't necessarily know that the results of that are going to give folks, because that gel can also pump off. I don't necessarily know that that will provide the relief that everyone's looking for. And again, I'm not an eye surgeon, but so I would certainly say if they are that bothersome, discuss them with your eye doctor. But for most folks, floaters generally become less noticeable as we become more used to them.
And then the other question, this is going back to the computer screens, just if there are blue light contacts. I don't know if that's a question of there are, and are those effective, or is that a thing that exists?
No, I'm sure there are. I mean, there are blue light glasses that can block some of that blue light. It's not that the blue light is necessarily damaging your vision. It's more that it's going to affect sleep cycles. So really, the point that I would say is if you have the access to those glasses, and just being really careful at night with screen time, especially within the hour to 2 hours before you're going to bed.
Wonderful, thank you.
Absolutely. I will move on to hearing. And if anybody has questions as we go along, feel free to drop them in the chat. Even if it's about vision, we'll have another chance for questions at the end. So next, I want to talk about hearing and hearing loss, which a lot of folks deal with. In folks 65 to 74, around a third of older adults in that group have hearing loss. By the time we reach 75 and over, around half of people will be experiencing some type of hearing loss. And the list of things that cause hearing loss is way longer than that. Some of the biggest things, aging itself can cause problems with the nerve. Noise, very loud noise, either repeated exposure or even single time exposure to extremely loud noises can cause it. Certain diseases, certain medications, and hereditary conditions, so inherited conditions. There are really two major types of hearing loss that we think about. The one on the left, sensory neural hearing loss, really relates to the nerves. It relates to sound getting processed and sent to the brain. This type of hearing is seen aging with damage to the nerve from noise, with certain drug side effects. There are a few antibiotics in particular that can do this. Generally, things that you might be seeing if you're in the hospital. Tumors, large blasts, or explosions. On the right side, I focus on what's called conductive hearing loss. And this is really point A to point B within the ear canal itself. So is there something physically blocking the passage of sound? Something like a fluid, foreign object, impacted earwax, allergies that can cause that ear congestion that people feel, or has the eardrum itself actually been ruptured? And I want to make a special point here as I talk about foreign objects. You'll notice the one that they picked here is a Q-tip. I'm going to talk about why. The other question that folks often have is, how loud is too loud? At what point do we start damaging our ears from sound? And really, so this conversation is probably on the realm of 60 decibels, depending on how loud your speakers are. Busy city traffic can be 85 decibels. Now, if you're sitting on a busy street corner for 8 hours a day, you are just hitting that safe level of exposure. And hopefully you're not doing that, but anyway. Once you get beyond that, imagine listening to a hairdryer at full volume for 8 hours a day. Some folks will be working on the street doing jackhammering on a sidewalk. If you're not wearing proper ear protection and doing that for a long time a day, that can cause some hearing damage. Gunshots and fireworks tend to be so loud and so explosive that even in shorter bursts, they can cause almost instant damage. So once you start getting toward the right here, we really need to be careful with ear protection, either earplugs or other sound barriers, or if you can, distance. So how do you know if you have hearing loss? You might if some of these things apply to you. If you find yourself having trouble hearing when you're using the phone, if you find it really tough to hear when more than one person is talking, which can be a common situation. You're in a crowd, multiple people are talking, you kind of have a hard time discerning who is talking or what they're saying. If you're finding that you often need folks to repeat what they're saying, or if your friends, partner, significant other, whoever you're around is complaining that you make the TV really loud and you don't seem to see a problem with that, that can sometimes be a sign of hearing loss. If background noise makes it harder for you to hear, if you are kind of convinced that others are mumbling and your hearing you think is just fine, sometimes a sign of hearing loss. And the inability to hear higher pitched voices, or lessened ability to hear higher pitched voices. As we age, our ability to hear high pitched sounds goes down, starting as early as your 20s. And by the 30s, it actually starts to go down pretty significantly. As we go through all of this, it's really important to recognize that even though hearing loss can be a process that we see, that we know happens, any kind of sudden hearing loss is really a medical emergency. If you find that you're sitting there and you go completely deaf in one or both ears, that is something that needs to be evaluated the same day. So again, prevention, as I said last time, is really, really important. As with vision, some types of hearing loss are preventable, namely those caused by sound exposure. Some, like the hearing loss caused by aging, not entirely preventable. Most obvious one, avoid loud noises, use ear protection. The one that I find people disagree with me on the most is do not put the foreign bodies in your ear. And by that, I mean Q-tips. Do not use Q-tips. You are not making it better. The ears have a really good way of cleaning themselves out generally. So putting Q-tips in to deal with earwax really does just one thing. Well, two things. One is it pushes the earwax further in and can make it impacted. And two, you can lose part of the Q-tip in your ear. So it's not very infrequently that when I look in someone's ears, they tell me, oh, I think I have a lot of wax. I also find a little piece of the Q-tip fuzz in there. So really, if you're worried about wax buildup, there are a couple of other things you can do. One is see your doctor. We have many ways of getting it out. We can flush it out with water. We can use a little device under direct visualization and actually remove it ourselves. We can give you little drops that'll help soften it and make it come out. Don't stick things in there. It'll make all of our lives better. As with vision, managing your chronic conditions, things like diabetes and blood pressure also help with hearing. Uncontrolled diabetes, uncontrolled blood pressure has been linked to worse hearing. And checking with doctors before taking certain medications. As with most things, we recommend not just taking a bunch of over-the-counter stuff, because some of those medications, even the ones prescribed over-the-counter, have been tied to hearing loss. So let's say you decide, I'm a little concerned about this and I want to be checked out. Who do I see and what are they going to do? A lot of different folks can assess hearing loss. Primary care docs like myself, otolaryngologists or ENTs, as well as audiologists who are really specialists in hearing. They're not physicians, but they are hearing specialists. The first step in evaluation is pretty simple. It's looking in there to see what's going on. Sometimes we can fix a problem by taking out some of that crazy wax that's built up and removing that piece of the Q-tip that's been in there for a few weeks. Again, don't try it at home. Let us do it. We're happy to do it. If we're not really seeing anything, if your ears look normal, we have a few other more specialized tests that we might do, even in the primary care world. But at that point, you may be referred for some formal hearing testing that can help us determine the cause of your hearing loss. So now the big question is, you've gone to one of those specialists. How do we not just live, but how do you really thrive even with hearing loss? The goal of all of this, if we have to age, we might as well age well. So some very, very basic and fairly straightforward coping strategies, in addition to addressing these issues with your doctor. If you have a hearing problem and you're not hearing what others are saying, a lot of people try to kind of go with it and just nod and smile. Informing others of your hearing problem and asking them to speak louder if you feel comfortable doing so can really help you get back involved in the conversation. Paying closer attention to facial expressions and gestures for context can also be helpful. Asking for some kind of repetition, rewording, clarification, and ensuring that you're in the best possible environment for listening. If you're sitting down with someone to have a really intense or in-depth conversation, and it is in a place like the Jefferson cafeteria that is almost always loud, that may not be the place to have that conversation. It's also important to think these are things that we can do ourselves. It's also important for us to remember these things when we're working with others who are experiencing hearing loss as well. Doesn't mean we have to shout. As a geriatrician, I've developed the skill of raising my voice without yelling. And it's something that pretty much anyone can do with some practice. That said, it's not all raising voice. There are other things that we can be doing as well, which are hearing aids. And hearing aids used to be these large, bulky devices that people didn't like. They were and still, unfortunately, are quite expensive, but we're going to talk a little bit about how that may change in the near future. These devices are getting better quality and smaller by the year. And I want to talk a little bit about the different types of hearing aids. Two big categories. One goes in the ear, one goes behind the ear. And if you look here on the slide, you will see an example of each of these, kind of top to bottom, left to right for the photos. So these in the ear ones start with the one that's on the very left, invisible or completely in the canal. These are really, really small to the point where they are not easily visible. So if you're worried about cosmetics, that can be, this can fix that problem. The sound quality from these tends to be pretty good because it is pretty far in the ear. That said, if you have trouble with vision, if you have trouble using your hands with what we would call dexterity, these are tiny. They're easy to lose, and they can be hard to put in. It can be really hard to change the batteries, as anyone who has ever struggled with a hearing aid can tell you. So if that's a problem, you can think about the in the canal hearing aids, which are still pretty small, can still give you really good sound quality, but a little bit bigger. Again, not right for everyone. So they do have these, what they call low profile ones. By low profile, some folks might look at this and say, well, that still looks pretty big. That basically means it's not sticking out of the ear. They're larger, they're more visible, still with good sound quality. For others, they prefer in the ear, behind the ear type hearing aids. There are two major categories here. One are called the receiver in the ear, which you'll see on the left side here. And these are really nice because they actually have rechargeable batteries. The battery is held over here. The microphone is toward the back, and the speaker is in the ear. The ear mold systems are on the right here, some of the more classic ones. You'll see them often used in children because those ear molds can be switched out for comfort and for size. Again, the microphone is on the back part. The actual the microphone and the speaker is inside the ear. Ear mold type hearing aids tend to be really good for very severe hearing loss as well. So folks often say, well, what's the best style of hearing aid? And for here, it's kind of some of the issues that I've already brought up. If you are new to hearing aids and if you have any dexterity issues, those tiny ones are probably not the best. If you are really staying at home most of the time, or if you're restricted, some folks don't necessarily care as much about how it looks in that case. So they will go with the bigger devices that are a little bit easier to work with. And if your hearing loss is really severe, there are specific types. Those low profile or those behind the ear with ear mold tend to be really a little bit better in the severe hearing loss. Now the bad news, which I'm sure some folks out here have run into. Original Medicare, meaning if you're not in a Medicare Advantage or a Part C plan, doesn't cover hearing aids. Great. And by great, I mean it's terrible. I mean, it should change. There have been multiple efforts to make some headway with this. But as of now, Medicare still doesn't cover it, and they can be pretty expensive. That said, it's still worth in most cases getting evaluated by an audiologist and talking to them about some cost assistance programs and financing options. There are monthly payment plans for some of these. There are also there's some hope down the line for over-the-counter hearing aids, which is something that is relatively new. A 2017 law actually allowed these devices to be sold over the counter as kind of a one-size-fits-all more approach. And the benefit to these is that they can be pretty cheap. This pair that you see here, not that I'm endorsing any product, can be found at major retailer for under $40. Quality may not be what you'll get with a medical grade prescribed hearing aid, but as with many things in this country, we sometimes have to work around the system. And so in this case, these can be more cost-effective options. They're available on Amazon, they're available at Walmart, Target, and I assume some local pharmacies as well. There are a number of other ways that we can assist with hearing as well. Some folks with really severe hearing issues do set up these alert systems for home, for things like doorbells, smoke alarms, and alarm clocks that can use lights or some kind of visual signal or a vibration to get the measure across. There is increasingly excellent speech-to-text technology for both cell phones as well as home phones. If you have an Android phone, Google has a feature called Google Live Transcribe that can actually listen in on your phone call if you feel comfortable letting Google do such a thing. And it will actually, with pretty good accuracy, type it out for you on your screen live. There are a number of other apps, but I don't use any one of them enough to fully endorse one or the other. So that's really the bulk of my content here. I wanted to give folks another chance to ask any questions. And I know this is kind of a 90,000 foot view, but the things that I really want to hammer in here is that one, prevention for both ocular and vision and hearing issues. And two, we as primary care, we as physicians are happy to work with you all.
So Michael, you kind of ran through in the vision section, the frequency with which someone should get their vision checked. Are there similar recommendations for hearing tests?
It's very interesting in that there actually aren't the same level of recommendations, in that we really, vision we measure it regularly. Right. Hearing is more of an experienced or a lived thing. So if folks are satisfied with their hearing, we won't say you need hearing aids. Whereas if your vision is under a certain level, we do say you need glasses if you want to do things like drive. So at this point, the major societies have not come out with, you should get your hearing tested every year or every 2 years. It's really, if you're noticing issues or if you're concerned, that's when you get tested.
Thanks. And again, would encourage folks, if you have questions, to drop those in the chat or the Q&A. Or again, Michael, you may have preempted everyone's questions by anticipating the commonly asked ones.
Fair enough. Hopefully I didn't bore everyone to sleep, but thanks for having me again. And happy to do it.
Yeah, very good to have you back.
And I
yes,
saw a comment
Jimmy,
about no Q-tips, but yes, that is the other point that I want to leave you all with. Don't stick the Q-tips in there.
That is good to know. That is good to know. I admit I have been guilty of that one in the past too. There actually was a question that just came in, and I'll expand on it a little bit. Is it better to get eye exams at just like a place like LensCrafters? Are you losing any sort of quality at one of these more commercial chains versus going to a medical office?
You really aren't, in that if you're getting an eye exam at LensCrafters, it's to my knowledge, it's done by an optometrist, so an eye doctor. The one other kind of distinction that I want to put out there is if you are working with someone who is an optician, that is different. Now, these are not folks who are going to be examining your eyes, but if you ever do see someone who is an optician, opticians are really specialists in glasses by themselves. They make glasses, they fit for glasses, but they are not the ones doing the exam. So even if you go to one of these big chains, it is totally fine to get your eye exam done there.